Thank you all for the great opportunity to be in front of you all here at ISC. My name's Alpesh Amin, and I'm at the University of California, Irvine. I am involved I do a number of things in the area of anticoagulation, VTE prevention, and have published a lot in terms of health outcomes research in the area of VTE and VTE prevention. So it's a pleasure to be here, and I'm joined by Dr. Christine Roff, who is from the UK, and it's great to have her from Keele University to help give this presentation with. So we're gonna talk about some of the practical challenges with VTE prevention in stroke patients, and so I'm gonna give the first half, and Dr. Roff is gonna give the second half. So thank you for the opportunity. You know, as many of you know, prevention of venous thromboembolism, or DVT, and hospital-acquired DVT has been named as a public health issue, right? You know, we know that it has spanned over 2 decades, in terms of us trying to get prophylaxis education out there. More than 90% of non-surgical hospitalized patients are at high risk for this. There's a 2% rate of preventable DVTs have been reported by accrediting organizations. The prevention of DVT is being driven by a lot of regulatory and quality organizations like the Joint Commission. Part of the problem is the concern around bleeding. It's always a risk-benefit issue that we have learned. And, when you're dealing with a population like stroke, you know that these patients are at high risk of venous thromboembolism, but they're also at high risk of, and DVT, but they're also at high risk of bleeding. So you don't get one without the other. So we have to be smart about how we deal with it and manage it. The prevalence, despite all the stuff that we're doing in this world, the prevalence continues to keep rising, and you can obviously talk about why. A lot of it has to do with the aging of the population, people having more diseases and more comorbidities and obesity as a result of living longer, and so that obviously contributes to it. But despite all the stuff that we've done in the area of prevention, we still see this issue rising across the United States. And yes, there are quality measures out there, but there's also gaps associated with these quality measures, right? We've learned about VTE1 and VTE2, which talks about prevention in both on the medical surgical floors as well as in the ICU, and VTE6, which is the measure that looks at preventable hospital-acquired VTEs, and the goal of that to be lower the better. But despite these quality measures, I'm gonna prove to you that we have gaps in our care processes. And as we've measured this through either the Surgical Care Improvement Project, SCIP, which has a VTE1, VTE core measure, and the VTE1, VTE2 measured through the Joint Commission, we can see that we're achieving more than 90% from process measures, which are different than outcome measures. We're able to check a box and achieve more than 90% VTE prevention, but that doesn't mean that we're actually preventing the DVTs that we need to prevent necessarily. And in the medical population, unlike the surgical population, we have data that shows that there are more than 8 million non-surgical hospitalized patients every year that actually need DVT prophylaxis, right? You could see that it's more than 8 million, because this data is a few years old. And on the surgical side, you're talking about over 4 million patients that need it. So that's a huge number of patients that need it. And we have algorithms that we've looked at, but when we go down the algorithm, I'm going to share with you that, look, yes, we have hospitalized medical patients that need VTE prevention, but 1/3 of them actually get no VTE prophylaxis. And then 2/3 get some form of VTE prophylaxis. But when you ask the question whether they get it according to appropriate guidelines, right? Because guidelines mean type, dosage, and duration of prophylaxis. You will see of the 2/3 that actually get some form of prophylaxis, about half of them get it according to guidelines, and half of them get it not according to guidelines. And I've published results that have showed that if you actually follow guidelines in a large population of patients of over 300 hospitals I looked at, if you follow guidelines, you actually show a statistically significant reduction in mortality. You show a statistically significant reduction in length of stay. You show a statistically significant reduction in overall cost if we follow guidelines. But you can see we don't, so when we start measuring, it's about doing the right thing, and you can see we run into those issues. And then of the patients that are supposed to get guideline-directed appropriate prophylaxis, that 50% of the 2/3 that actually get anything done, again, one quarter of them get prophylaxis from mechanical device, and then the other close to over 70 to 80% actually get it from either some combination of anticoagulation or anticoagulation plus a mechanical device. And then you could see the breakdown at the bottom in terms of IPC versus GCS devices. So again, more than 70% of patients at high risk for VTE do not get appropriate prophylaxis. Remember, we're here to provide high-quality health care, and we haven't been able to achieve that in our 8 million patients that we need to achieve that in. And you could see that there has been a decline in VTE prevention. It's declined down over the years in terms of preventable DVTs, in terms of process measures, down to 2% range, as you can see here. And despite this, when we look at real-world data, and this is a publication that I published, we can see in over 5,000 patients that real-world symptomatic VTE rates are still 2 to 3 times higher than the expected DVT prophylaxis if you were to look at observed over expected kind of models. And this is looking at now the non-surgical population, and again, looking at the proportion of patients that have underutilized in the high-risk VTE population for prophylaxis, and you can see it's, again, in the 30 to 40% range. And then for the area that is that you are here and most interested in, let's talk about what the risk is in terms of the cardiovascular population, and then the risk in terms of the stroke population. And you can see of about 38%, almost 40% of patients that are at risk for venous thromboembolism fall into the cardiovascular population. This is 72% of them fall into cardiovascular and respiratory diseases. Of that 38%, about 1.8 million are heart failure, another 500,000 or so are acute MI, another 500,000 or so are strokes. So again, it's a significant proportion of the patients because you're talking about 1/6 of that 40% population. When we've asked the question in stroke patients in the stroke population, what is the high rates of VTE and bleeding that occur at days 30 and 90? When you look at Dexter claims data, which is from the CMS Medicare database, you can see that the rates of VTE readmissions and the rates of bleeding readmissions at 30 days and at 90 days, both for ischemic stroke and hemorrhagic stroke, you could see, is quite significant, and the bleeds are higher at 30 days and the readmissions are higher, and again, even at 90 days. So it's still quite significant, and this is based on 2018 data. So we do worry about this, and there are patients that come in with ischemic stroke that have a risk for hemorrhagic stroke, but we don't always look at that the way we should and risk stratify these patients. So then we also looked at some more data where we looked at Medicare stroke patients and in 2018, and patients with stroke plus an IPC contraindication made up about 15%. Stroke plus at least an anticoagulation contraindication made up about 21%, and stroke with anticoagulation and IPC contraindication made up about 8%. So when you look at this total population, there is a group of patients that don't easily get fit into the category that we know that they need prophylaxis, they can't take an anticoagulant, and they can't take a mechanical device. So where's the disconnect in everything that we're talking about? And we have, over the last 20 years, looked at guideline-directed therapy and risk stratification. And here's the Padua scoring system that's been published. And when you look at this, you can see that the ACCP recommends, American College of Chest Physicians recommends using the Padua score. Many of the risk factors here, even though it talks about the acute medical population, are similar risk factors that you will see in your stroke population. 11% 90-day risk of symptomatic VTE in hospitalized high-risk non-surgical patients exist as a result. Besides that, the improved risk stratification is shown here. And when you look at the improved risk stratification and you look at patients that are with stroke, you need greater than 2 to say that the patient's at risk of stroke. Well, many of our stroke patients have lower limb paralysis, which gives them 2 points. Immobilization for more than 7 days gives them a point. ICU stay gives them a point. And greater than 60 years of age gives them a point. So many of our patients fall into that risk stratification of high risk for VTE, but not always do they fall into that high risk of bleeding in the same way, but they do, because a lot of the risk factors also fall into that category. We also have, and here's a typical protocol of a stroke patient, right? They tend to be age greater than 60, be in an ICU, immobilization greater than 7 days. So the probability of symptomatic VTE is more than 1.5%, but the probability of having a bleed, male, age to 40 to 80, could be in an ICU, bleeding risk, right? The risk of bleeding is also quite high in many of these patients, which makes our ability to coagulate and prevent VTE a challenge in some sense. The American Society of Hematology has published guidelines on what should be done, and they favor anticoagulation, as you can see here, but then they also make a comment about the risk of bleeding. The AHA stroke guidelines actually have an interesting differentiation that I want to point out, and it says that they recommend that you should consider IPC unless contraindicated. In immobile stroke patients without contraindications, intermittent pneumatic compression, in addition to routine care, aspirin and hydration, is recommended over routine care to reduce the risk of DVT. So this is one category of patients where anticoagulants may not be the overall answer for prevention of VTE in stroke patients because of the risk of bleeding and all the things that I've talked about. And it says, again, in ischemic stroke, elastic compression stockings should not be used. So, you know, and then it goes on to talk about anticoagulation. Then when you go to the NICE guidelines in Europe, in 2018, they talk about they talk about not using anti-embolism stockings for VTE prophylaxis. They talk about intermittent pneumatic compression for VTE prophylaxis in patients that are immobile. And then they go on and have further recommendations, you know, in terms of intermittent pneumatic compression devices to reduce the risk of venous thromboembolism. So again, the issues of anticoagulation come to bear in some sense. So what do? There is a population of patients here, and it may be even more so in the stroke population, where anticoagulation is not acceptable because of the risk of bleeding, and yet also compression devices may also have some contraindications, and we need to do something about the VTE prevention. And so my colleague is going to talk about another novel therapeutic option, Gecko, which she'll talk about, that may fit into this space that you see up here. I want to end with this one last quick discussion around a gap across the continuum, which is lots of patients have venous thromboembolism risk across the continuum, but we're not able to give anticoagulation to them. The risk is high. People get DVTs. If you look at this graph that I published a few years ago, it shows that within the 5 days post-hospitalization up to about 35 days, the risk for thromboembolism is quite high. In the medical population, this also shows the same thing in the surgical population. But when we've done clinical trials, we have not been able to find a net clinical benefit because the risk of bleeding outweighs the risk of thrombosis. So we have a gap in the post-hospital patients in terms of VTE prevention. And the risk actually doubles in post-discharge over a 21-day period, and the mortality actually increases by 5-fold. So again, we have an opportunity to think about this.